Welcome everyone to the National Fellows Online Lecture Series, sponsored by AMSSM, the Online Fellows Education Subcommittee, the Education Committee, and the Fellowship Committee. Today's online lecture series is High-Yield Ultrasound for the CAQ, and we are very fortunate to have both Drs. Emily Dixon and Dr. Ryan Kruse, who I'm sure many of you recognize from all of the lectures they do on ultrasound, both at the national conference and throughout the year. They've both agreed to share their expertise this evening. Next week, we have a CAQ question session, which is headed by Dr. Emily Eshelman and Dr. Hamish Kerr. That is also at 8:30 Eastern Time PM. This is supposed to serve as an adjunct to your individual program's educational programming, provide fellows with direct access to educational experiences with experienced AMSSM members and at times invited guest speakers, and assist in CAQ exam preparation. Please mute your device, microphone, and turn off your video. Submit questions through the chat function. I will ask the questions during Q&A at the end, and please complete the evaluation at the end of the lecture. Dr. Emily Dixon, her education was, she went to medical school at Ohio University College of Osteopathic Medicine. She did a family medicine residency in Bethesda, at the Bethesda Family Medicine in Cincinnati, Ohio, and her fellowship was at Beacon Orthopedics and Sports Medicine. I always think it's pretty great when people are kept where they did their fellowship because that means they were pretty stellar, and she still works at Beacon Orthopedics and Sports Med. She is a team physician at Xavier University, and she is on faculty at Tri-Health Primary Care Sports Medicine Fellowship. For fun, she summited Mount Kilimanjaro in Tanzania with her husband, and mostly for fun, she is the AMSSM Ultrasound Committee co-director of the Fundamentals Ultrasound course. Dr. Ryan Kruse, his education was at St. George's University in Grenada, West Indies. His residency was in PM&R at the Mayo Clinic in Rochester, Minnesota, and his fellowship was at the University of Iowa in Iowa City. And believe it or not, he still also works at the University of Iowa. Again, somebody they didn't want to let go. He works as a network team physician for the United States Soccer Federation. For fun, as you can see, he travels for work and wears the uniform. And he is the AMSSM Ultrasound Committee Education Subcommittee Chair. With that note, I'll stop sharing my screen and invite Dr. Dixon to start sharing. Thank you again.
All right, so everyone can see that? We're good? Okay, so I have no financial relationships to disclose. We're going to start talking with physics of ultrasound, which is a terribly boring topic, but I think everyone will be shocked about how many questions you actually get on your CAQ. And then if you do any RMSK ultrasound certification through the AIUM, there's a lot of physics questions. Most of us are very lucky. Most of our ultrasound machines do this for us. But you really kind of need to inherently know how the machines work. So when we talk about ultrasound, the biggest thing is the ultrasound transducer, the piezoelectric effect is actually the crystals in the end of the transducer that send an electrical signal out into the body, and then that converts and is reflected back into the transducer, and then that is converted into what we see on our screen. So the piezoelectric effect is really important. This is also why the ultrasound reps don't want you dropping your probes or damaging them or etching them, because that can affect the piezoelectric effect. The sound waves go through the soft tissue, and at different tissue interfaces, that's when you get different impedance, and then that sound waves reflects back to the probe. So that's why we get different signals for different structures in the body, bone being bright white, fluid being dark black. The physics of the ultrasound, the biggest thing is when we're holding that transducer, that ultrasound wave should go out to the body, and then it should come back to the probe. The most perpendicular you can get to the probe, the brightest of a signal you're going to see. But sound waves are also absorbed or refracted. So if you have a patient who's had a ORIF at the ankle and they have a metal plate on their medial malleolus, those signals could be reflected off. The heavier a patient is, more adipose tissue you have, the more that signal is going to be absorbed. So just knowing that we have different signal impedance can affect the picture on your screen. The focal point, most ultrasound machines these days, we can change our focal point and adjust to where you want the machine to kind of focus the signal to. And you can continuously change that. So if you're looking at a very superficial structure, say we're looking at a long head of the biceps tendon, the focal point might be higher on the screen, but then if we go deeper to the posterior glenohumeral joint, you may need to change that focal point to a little bit deeper. Luckily, a lot of our ultrasound machines now can automatically do that with their algorithms. So the image quality is completely related to the frequency. Higher the frequency in megahertz, the higher the resolution, but there's a higher absorption due to attenuation. So if you have a linear probe or a little hockey stick probe, you're gonna get an amazing picture. But if you try to use that hockey stick probe and look at a hip joint, you're not gonna be able to see the hip joint. So the analogy that people like to use is a high frequency probe is like a piccolo in an orchestra. So really high pitched, high frequency probe, you get a great resolution, but there is higher absorption. It can't penetrate as deep. A low frequency probe is going to have a lower wavelength of megahertz. So this is like an elephant trumpets, or like if you're behind a car who's bumping the bass, you can hear that lower frequency a lot further away, and then that sound beam will penetrate deeper. So again, signals propagated in a linear fashion. So a linear transducer is going to put the signal out straight. A curvilinear is going to send it out in a pi. But as you can imagine, as that pi signal goes out, you might get some refraction or absorption as the ultrasound beams going back a little bit differently. So a wider field of view, you may need to use for deeper structures like a hip, or even sometimes if you have a really muscular person, I like to use a curvilinear probe for a glenohumeral joint. So your transducer choice is, very user dependent. I am very picky about what I like to use, and my assistants know usually what I'm going to scan, what transducer I'm going to use. Superficial structures, again, the higher linear frequency transducer. So you can see in the picture in the bottom right, my 12 linear transducer I use a lot. Deeper structures, I'll use my curvilinear, that's 1 to 5 megahertz. Foot and ankles, a lot of times we'll use a hockey stick. Sonosite, I call it the little guy, has a little tiny linear transducer. And then don't be afraid to change your gain. So sometimes a picture can look very dark, so adjusting the gain up can help. For example, plantar fascia tends to be a kind of a darker structure, so making sure we can adjust that gain so that you can increase or decrease the brightness of the echo signal. Scanning technique. I get on my fellows all the time. Do not walk the dog by its tail, which means make sure we have a nice imprint of our hand. We're holding the probe steady. We're not doing jerky movements. So I actually reviewed a question in one of the old CAQ review books that AMSSM puts out. And one of the questions was how to optimize the image. So you may even have questions like that on your CAQ. Transducer movement, we talk a lot about heel to toe maneuver. So that's tilting your probe forward and back when it's rocked and angled along the long axis of that transducer. A toggle is when we angle it side to side. So sometimes if you just shift your probe slightly from one side to the other, you may be able to optimize your image, or vice versa, make the image look worse. What I always like to tell my fellows, when you think about if you're doing an injection and you have a 27 gauge needle, that needle is tiny. So if you have, sometimes you have to toggle or do a slide or sweep to make sure you get that needle perfectly in plane, because the needle is so much smaller than the transducer. Same thing if you're looking at a smaller structure like a posterior tibialis tendon or a long head of the biceps, that's going to be a smaller structure than like a supraspinatus tendon or a glute tendon. So scanning protocols, the most important thing that we like to teach is knowing what your scanning protocol is and keeping it consistent. So I always was taught left is medial and distal, right is lateral and proximal, but the biggest thing is knowing which way your probe is moving. The last thing you want to have is be doing a procedure and have your needle come from the wrong side of the screen. So we always image in a short and long axis view is what we like to call. We don't say necessarily sagittal, coronal, axial, because a lot of the tendons of the body don't perfectly follow those planes. Our goal is always to eliminate artifacts in our image and then ensure transducer is in the proper plane to pathology. So if you can see on the left side here, we have the long axis kind of transducer position. This is the quadricep tendon patella. I like my probe to move the way that it's moving on the body, and it should move the same way on the screen. So in this, distal would actually be on the left side, proximal to the right, quadricep tendon and femur, and then short axis, you flip 90 degrees on that structure, and then you can see in the star there, that's our quad tendon in kind of a perfect short axis plane. So in lingo, at this time of year, most fellows should hopefully be writing up ultrasound reports and describing what they're seeing in their notes. So hyperechoic is the sound beam is strongly reflected. So that's going to be a bright echo. So tendons and ligaments do tend to be more hypoechoic. Anechoic is no echo. So this fluid, it's black. So typically it's a ganglion cyst, a Baker cyst, a bladder, if you're doing any like lower abdomen stuff. Hypoechoic, it's an area with a weak or low echo. So like a muscle is going to be more hypoechoic compared to a tendon or a ligament. And isoechoic is when they're equal. So the most common area that I think is most isoechoic is the plantar fascia compared to the calcaneal fat pad. That's a very isoechoic structures. The biggest thing to remember too is that we are looking at a 3D structure on a 2D image. So I always like to talk to my fellows or people who I'm training that, you know, we're looking at a tendon or structure that is curving in and attaching to a bone. So anisotropy is a variation of the ultrasound interaction with the fibrillar structures of whether it's a tendon, ligament, muscle, or even some bones, but depending on where you're looking at it. So when the tendon is viewed perfectly perpendicular, we're going to get that great, nice, bright signal coming all the way back. But you can tilt your probe, do a heel toe maneuver or even a toggle, and you can make, like on the left side of the picture, you can make that anisotropy kind of pop out. So I can make any tendon look bad, but if you can correct that with a heel toe or some toggling, you can make that go away. So always make sure if you see something, if your eye catches something, oh, is that real or not? For example, I was doing a glute exam today and looked at the glute medius and minimus, and at first I was like, oh, they've got a big retracted tear, and I just realized no, I just didn't have my probe quite in plane. And as long as you can correct it and see that nice fibrillar pattern, just know that that's that anisotropy causing the issues. Artifacts are super common. So shadowing is when the ultrasound beam is reflected or absorbed. So in this example, on this calcific tendonitis on the right, you can see these big calcific structures, and you can see this posterior acoustic shadow behind it. In between the two, you can see that you can actually see some of that rotator cuff signal coming through. That can be from bone calcification or a foreign body. So if you have a patient who's stepped on a needle or has a metal fragment in their body, I once scanned a guy who had fallen in a cactus in Arizona, and he had all this posterior acoustic shadow from the cactus needles. Also, sometimes you can get some of this refractile shadowing if you see a tear. A very common example of that is a big Achilles tendon rupture. You'll see that shadowing coming down for where the two ends into the tendons are not connected. So comet tail is a short segment of posterior bright echoes that narrows down from the artifact. So it looks like a comet tail. A lot of times if you see people with gout tophi, or again, if you see a foreign body, you might see that comet tail effect. A ring down effect is very common if you see someone who's had surgical intervention like an ORIF, and you can see this these kind of ring down effect from where the metal was, or a screw or something like that. Increased through transmission is brighter signal through something like a bladder or fluid. And then posterior reverbs, it's when the surface of an object is kind of going right back here. That means you are perfectly in plane. So when you have a needle perfectly in plane on your injection picture, you should see those posterior reverbs. So this is an example of a posterior reverb deep to the needle. So you can see where you can see the needle refracting. And then this is an example of a Baker cyst with increased through transmission. So you can see how if you get right in the middle of the screen, behind that Baker cyst, you can see some of the tendons, the hyaline cartilage, even the posterior meniscus here, that looks brighter than the other structures. And that's completely secondary to that through transmission, and the fluid helps us. Same reason why when women are pregnant and they're doing anatomic scans, they want them to have a full bladder when they scan them. Doppler imaging should be used quite frequently. Almost every ultrasound machine should have that now. If it doesn't, that would be incredibly unusual. Red represents blood flow towards an image. Blue, it's when it's flowing away. but it's very sensitive to movement of the probe. So if you put your Doppler on, you need to make sure your probe is very still. Any slight tiny shift, or it's going to make the screen go crazy. So just be very aware of this. But we use it a lot for synovitis, to look for neovessels and acute tendinosis, that sort of things. So this is an example of an Achilles tendon that has some neovessels in it and some irritation. Very helpful to use your Doppler imaging and identifying vascular structures. So that's just a common thing for me. Before I do an injection, I always put my Doppler on to make sure I'm not missing some sort of small vascular structure that I could avoid. Also really good to differentiate between a mass or synovitis. So if you see a hot swollen knee, you see that gray wavy synovium there, you can kind of get that in plane and put the Doppler on to see if it's a true synovitis. And again, it's very much associated with inflammation and acuity. All right, and now we're going to switch back to Ryan.
All right, can you guys see that?
Yep.
All right, perfect. A couple of quick points about what Emily had said. So for most of us, the physics of ultrasound could not be more boring. However, it's arguably probably the most important part of your CAQ. I mean, you're going to get innumerable questions on ultrasound physics and artifacts and whatnot. So that's super high yield stuff that Emily said there. And I would really kind of rewatch this and make sure you understand everything that she talked about there. All right, so we are going to talk about the normal appearance of common MSK structures, what the pathologic appearance is of those structures, and then I will go through common lower limb structures, and then I'll bounce it back to Emily, and she'll go over common upper limb structures that you should be able to identify sonographically. All right, so most of this is going to be very basic, but it is important because you will get questions about what these structures look like in their normal and pathologic state. So we'll talk about tendons, ligaments, muscles, nerves, and bones. All right, so we all know this. Tendons look different. All these structures look different, whether or not we're looking at them in a long axis versus a short axis appearance. So starting with tendon, so long axis, pretty classic appearance. You have this nice hyperechoic fibrillar or linear appearance that we talk about. And again, this is in a long axis or parallel to the tendon fibers. When we rotate our transducer 90 degrees and we're more perpendicular to these fibers, the appearance changes a bit, and we kind of describe this as more of a broom end appearance. So you get this kind of hyperechoic appearance with these fairly hypoechoic spectations or speckled dots throughout the tendon. So that's what a normal tendon looks like in short axis for the most part. Come on. All right. So for all of these structures, you have to know what normal looks like to be able to understand what abnormal looks like. If you don't know what normal is, then you're kind of just shooting in the dark in terms of deciding what's abnormal versus not. So in an abnormal tendon state or a state of tendinosis or tendinopathy, tendons will become thicker. So that's very common. They'll become more hypoechoic. So you can see this is Achilles here, relatively normal, getting close to the mid-substance here. Again, bright white, hyperechoic, fibrillar, and very clearly here, this is very disorganized, hypoechoic. That's a classic appearance of a tendinopathic tendon. Like Emily mentioned, these neovessels that we'll see within tendons, so that's very commonly seen in a state of tendinosis. And then also look for secondary signs, right? So these cortical regularities will clue you into this being a chronic problem. I could see that potentially being a question, which of these findings would be more associated with a chronic tendinopathy versus an acute tear. If somebody had a normal tendon that they just blew through, their cortex for the most part is going to look normal. In a state of chronic tendinopathy, they're going to have these cortical regularities. So make sure you understand some of the secondary or associated signs in the state of tendinosis. Tears are pretty straightforward. You're looking for a defect or a gap in the tendon. Understanding, particularly for the cuff, what is a partial thickness, full thickness, partial width, full thickness, full width. I think understanding those nuances can be important. Emily mentioned some of the artifacts that we can see with ultrasound, and a common one we see in a tendon rupture is edge shadowing. So you get shadowing around the kind of curved ends of a completely torn tendon. So certainly that would be a reasonable question hey, this patient comes in with, this presentation, you see a tendon rupture. What artifact would you commonly see here? So again, understanding the artifacts in the context of the clinical presentation, I think can be quite important here. So again, you're just looking for discontinuity between tendon ends, and you often have an anechoic hematoma between tendon ends. Ligaments, for the most part, look the same as tendons. I mean, histologically, they're essentially the same. Again, they're hyperechoic, they're fibrillar, they're linear. So just understand what those look like. And then similarly, when you get into a state of a ligament injury or sprain, so these ligaments, they lose their normal hyperechoic appearance, they become more hypoechoic, they're less fibrillar. They, in a state of a ligament rupture or tear, those ligaments will retract back, right? And they can have kind of a wavy appearance. So loss of tension is something that we're looking for if somebody has a ligament rupture. And then, I don't know how they would ask this in a question, but certainly the dynamic nature of ultrasound, we all know, is one of the pros of ultrasound. So being able to dynamically assess for laxity is something that's important as well. Muscles. So muscles look very, very different, whether or not we are looking at them in a long axis or a short axis appearance. So we all know what muscles are made of, muscle fibers surrounded by fascia, and depending on which structure we are evaluating, the appearance of that structure on ultrasound will be different. And so when we're looking at muscle, for the most part, the muscle fibers and the fascicles are going to be relatively hypoechoic. The perimyceal tissue, connective tissue and then in any sort of intratendinous or intramuscular tendons are going to be more hyperechoic. So in a long axis view, or parallel to the muscle or to the muscle fibers, we're going to have kind of like a veins on a leaf, or a feather appearance. That's pretty classic here. And then in short axis, classically described as a starry night. This to me looks more like a ribeye, I think. But regardless, you can see very different appearance of muscles in a short axis versus a long axis. So understanding those is important. And I think understanding which components of the muscle contribute to the ultrasound image are important. Again, knowing that the fibers are hypoechoic and the perimyceal tissue is more hyperechoic. So muscle strain, this is an obnoxious bit. I need to change this. This is a very obnoxious video. So when we have a muscle strain, so obviously it's an acute injury here, we're going to lose that normal architecture. Now I'll come back with, because I wanted to get that video onto there, with tendons and ligaments. Classically, they go from a hyperechoic normal state to a hypoechoic pathologic state. Muscle doesn't necessarily follow that exact same or have those exact same characteristics. So you can see hypoechoic change in muscle in an injured state. You can also see hyperechoic change. I would say most commonly you're going to see hyperechogenicity within an abnormal muscle, and typically, and that represents muscle edema and microhemorrhaging. And what we typically see is kind of this fluffy, patchy, cloud-like appearance. This is a semi-T muscle in short axis. You can see relatively normal muscle here. But all of this, again, it's almost the analogy that I give. It's like you take a sweaty hand and smear it on a chalkboard. You just get this kind of fluffy white appearance here. And then similarly, in a long axis view, you can see these patchy regions here and here of hyperechogenicity. So this is what muscle edema looks like. Muscle tears are fairly straightforward. You're going to be seeing fiber disruption and usually a anechoic or maybe sometimes heterogeneous hematoma within the site of tear. Commonly will occur at the aponeurosis between two muscles. And again, you're essentially just looking for a hole in the muscle, right? So this is an adductor. You've got fairly normal adductor muscle down here, and very clearly you've got a big black anechoic hole within the muscle. So these large tears are actually fairly easy to appreciate in ultrasound. So nerves. So again, knowing the components of the nerves and how they contribute to the sonographic appearance. So the individual fascicles within a nerve tend to appear hypoechoic or dark or even relatively anechoic. And the perineurium and the epineurium appears as a hyperechoic structure. Now in short axis, the classic description here is a honeycomb. Now that's the case for larger nerves. Now certainly for small kind of monofascicular nerves, you might not get that honeycomb appearance. It might just look anechoic. But for the most part, for most nerves, larger nerves, they're going to see this nice honeycomb appearance in short axis. And then in long axis, so similar to a tendon, so it's linear, but clearly it looks very different. So you've got large fascicles here and large perifascicular tissue, perineurium, almost as like a train track appearance. So that's the main way to, in long axis, to differentiate these nerves from tendons. What does a pathologic nerve look like? So again, normally you have that honeycomb or train track appearance. When a nerve gets swollen or becomes swollen or edematous, that fluid appears as a hypoechoic region. You lose that normal linear, not necessarily fibrillar, but you lose that normal linear pattern here. And so a nerve becomes thickened and swollen and hypoechoic. And oftentimes you'll see focal regions of compression. So this is what a bad nerve or an ugly nerve looks like. In long axis here, this is an ulnar nerve. And then this is a actually interdigital nerve or neuroma, excuse me, here. So again, bottom line, it gets thicker. You lose that normal train track or honeycomb appearance and it becomes more hypoechoic. I can't imagine actually them asking any question about nerve instability. So I guess just know that it happens and you can look at it with ultrasound and dynamically assess this. Bone's pretty straightforward. So normal bone should be smooth and hyperechoic and linear without any cortical disruptions. The caveat here is that small little feeder vessels can actually appear as a small cortical break. And so make sure you pay attention to that. If you throw Doppler on, make sure you apply light transducer pressure. And if you see a colorful pulsating thing going through, that's probably not a fracture. It's probably a feeder vessel, so just be aware of that and don't overcall fractures here. So pathology within a bone is fairly straightforward. This clearly is not a feeder vessel. This is a obvious cortical disruption in the bone here, so you can pick these up pretty easily. So again, you're looking for discontinuity in the cortex, and there are various secondary signs that we look for. So you can look for a perifracture or a pericortical hematoma. In the state of a stress fracture, similarly, you can look for periosteal or pericortical edema here, soft tissue edema. This is fairly subtle, but you can see periosteal or subcutaneous soft tissue hyperemia as well. And really the key here is if you see something that you think might be pathologic, be somewhat gentle, but just press down with some sonal palpation, and that patient will 100% tell you if that is pathologic or not. All right, so those are the common appearances of normal and pathologic MSK structures. So then I'll talk about some common lower limb structures that you should be able to identify. You know, I had quite a few of these identification questions on my CAQ, so I think it's important to know not only what these structures look like, but I think also the relevant regional anatomy is also important. So again, lower limb, we'll just go top down. We'll start from hip and go down to the foot. Now, again, this is most certainly not all-encompassing, all-inclusive here, but I think these are your highest yield structures that you should know. So the proximal hamstring tendon, these are easy to ask questions on. And I think just for these, knowing, well, one, what the two tendons are up there, and two, where they live. And I think knowing their relevant anatomy both at the ischial tuberosity and then down at the hyperechoic triangle is important. So if you remember, the semimembranosus tendon is going to sit deep and lateral to the conjoint tendon. Conjoint kind of sits at the peak or the apex of the ischial tuberosity. Gmax overlies it, and sciatic nerve sits adjacent. And that flips a little bit. So remember, obviously your membranosus is your medial hamstring tendon, and so at the hyperechoic triangle, your membranosus tendon sits medial, but as we course proximally, it courses underneath and lateral to the conjoint tendon here. So just knowing, again, the relevant anatomy is certainly of the triangle here. I could see that be an easily testable region there. I could see them, potentially, giving you this image, right? This is obviously a hip joint here. So identifying femoral head, neck, femoral shaft, this is clearly the needle. A lot of these questions will be second and third order. So they may say, This patient comes in for an injection to this structure, and you say, I got that. This is a hip joint injection. But the question is, which neurovascular structure should you be aware of as you perform this injection? And so for this to be the lateral circumflex femoral artery. So just again, knowing the relevant anatomy here, I think is important. Iliopsoas tendon burst. I don't know. That might not be highly relevant here, but just be aware of what these structures are. Knowing that if you go too far medial, femoral neurovasculature is there. Know what your tendon looks like on top of the acetabulum, and then knowing what this muscle is. Obviously, it's the iliopsoas muscle complex. I don't think they'll get into the nuances of which portion of the muscle it is. They may, but just know that the iliopsoas portion sits medial, and the iliacus obviously sits, or some psoas portion sits medial. Iliacus portion is going to sit laterally. Gluteal tendons. I think the facets here are probably important. Asking which portion of the tendon inserts on which facet here. So we know that the glute min will insert or attach to the anterior facet, and then the gluteus medius has two portions, inserting on either the lateral facet or the posterior superior facet. So the anterior band attaches to the lateral facet, and the posterior band attaches to the posterior superior facet. Just knowing those two different attachment points, I think is important as well. That's probably the main takeaway for the gluteal tendons I could see on the test. Knee joints, just know where the target is, right? And know what the structures are. And this is going to look different in the in short axis versus long axis to the quadriceps here. So knowing that the quadriceps tendon sits up top here, in this view here, this is the prefemoral fat pad here. So knowing that your injection target is here. This is incorrect. Actually, no, it's not. Sorry. Knowing that your injection target is here, this would not be your injection technique. Going medial would not be advised. And then a long axis to the quad tendon here, knowing, again, regional anatomy. So this somewhat hypoechoic region here is the supratellar recess, triangular fat pad sitting further distal is your quad fat pad, and then this more rectangular fat pad sitting a bit more proximal is the prefemoral fat pad. So just knowing that the inner space or the region between those two fat pads is your SPR or your injection target for a knee. Quad muscles and tendons, I mean, pretty straightforward. There's 4 of them, obviously. I think knowing the layers of the quad tendon and which tendon components contribute to those layers could be important. So knowing that the rectus femoris layer is the most superficial, that's a trilaminar tendon. Knowing that the rectus femoris portion contributes to the superficial third of the tendon, the vastus lateralis and medialis contribute to the middle third of the tendon, and then the vastus intermedius forms your deep layer. Continuing to the lateral knee, probably the two most common structures here, one of which I didn't really point out, would be your IT band. But the other common structure, which I think would be easy to test on, would be the FCL or the LCL. And again, knowing the relevant anatomy here, knowing what hyperechoic structure this is deep, knowing that's your tibia, I think that could be a question they may ask. I could also see them potentially saying, this patient comes in with concern for lateral knee injury. In order to best optimize this structure in the image, how would you position your patient? So knowing that you want to put them into varus to put the ligament on tension, that could certainly be something that they ask. Pes tendons, pretty straightforward. So sartorius gracilis and semi-T. For this, knowing that your pes bursa sits between pes tendons and superficial to the MCL, I think that would be something to keep in mind. And also knowing the order of the tendons as they insert, knowing that going from proximal to distal or really anterior to posterior, it goes in the order of sartorius gracilis and semi-T. And I don't know where I learned this, but every single time I look at a pes bursa or think about a pes, the way I remember the order of the tendons. So pes anserine or anserinus means goose's foot, and SGT to me spells out sergeant. And I have this picture of this guy in my head every single time. So this is Sergeant Goose. And so that is how you can, kind of remember the order here. All right, down to the Achilles tendon or foot and ankle region, excuse me. So starting with the Achilles tendon, I don't think there's any way they ask you what tendon this is. I think that's pretty straightforward. But again, knowing what's around here. So this is Achilles and long axis, calcaneus here. Certainly knowing which bursae we're talking about. So, superficial to the tendon insertion is going to be the retro Achilles bursa. And then deep to the Achilles tendon between the Achilles and the calcaneus is going to be your retrocalcaneal bursa. So differentiating those two and knowing which is which, I think is quite important here. Continuing on the foot and ankle, we've got a couple more, and then we'll kick it back to Emily. ATFL, again, just knowing what the relevant anatomy is here. Your fibula tends to sit a bit more superficial here, so being able to identify that, it's pretty straightforward, I would say. About the fibular tendons, so again, regional anatomy here, I think is important, and so at the level of the retromalleolar groove, so your longest tendon is going to be a bit larger than your brevis tendon. I don't particularly like, the mnemonic of brevis and bone, B and B. So brevis sits deep and adjacent to the bone because that's not necessarily always the case. Myself as the perfect example, I can flip my tendons on top of each other, and then longest is next to bone, and then that mnemonic doesn't really work anymore. So when you're trying to identify these tendons, as you're scanning, just scan distally, see where they go. If one courses under the foot, there's your longest, and follow it back up. If one goes to the base of your fifth, that's brevis. I wouldn't rely on the brevis and bone. Adjacent, if you see any hypoechoic stuff over here that's not circumferential, it's usually brevis muscle belly, and the superior retinaculum sits on the on top. A lot of structures in the tarsal tunnel, and I think they could ask questions on any of them. So knowing the relevant structures here, knowing the mnemonic, so Tom, Dick, Panda, very nervous. Harry, so your posterior tib is the first structure that sits adjacent to the medial malleolus, your FDL tendon. Tibial nerve typically sits superficial to the FHL tendon, but sometimes these can look relatively similar on the ultrasound image, especially if you don't have a great ultrasound machine. So being able to differentiate those two is important. I could certainly see them asking about, the branches of the tibial nerve and giving you a clinical scenario. So making sure that the tibial nerve itself technically trifurcates into the medial calcaneal and then the medial and lateral plantar nerves, which then kind of leads into the plantar foot here, specifically the plantar fascia. So the first branch of the lateral plantar nerve, also known as the inferior calcaneal nerve, also known as Baxter's nerve, is a mimicker for plantar fasciopathy. So, they could give you a question of, hey, this patient came in with plantar heel pain. You performed the ultrasound here, which showed normal plantar fascia. What nerve may mimic plantar fasciopathy? So understanding that. It's also important to understand the anatomy of the plantar fascia. So there are two main cords. The central cord is your primary portion or component of the plantar fascia, and then your lateral cord. There's no central band. It's central cord, lateral cord. There is a medial band, which comes off and kind of blends with the adductor hallucis fascia. I don't think there's any way they ask that, but just, again, I think knowing central cord, lateral cord, and what they look like in both long axis and then short axis here. All right, I think those are the main structures for the lower limb. Again, a lot of this I think will be relevant regional anatomy and understanding, some of how these structures fit in with various clinical scenarios.
Okay, so I'm gonna take back over, and we are going to go over upper extremity now. And so like Ryan said, again, this is not all inclusive. We really try to look at what they asked and also the experience for us taking these courses. I recertified right before I went to Kilimanjaro, and I was kind of surprised at some of the questions. So like some of the question some of the oh, is that not working? Here we go. Can you all see that okay, Ryan? Is that good? Okay. So like Ryan, so some of the vignettes you'll get, it may be, this is a picture, this is a supraspinatus tendon tear, and identify the pathology of the picture, but often it may show some sort of pathology and then ask a case related question. That could be treatment. It could be, how do you optimize this image? Tell me about the, the physics of the ultrasound, that sort of stuff. So just knowing what you can identify. And as we all know, most of these tests that we take, sometimes the ultrasound pictures they give us are not great, much like the EKGs and everything else. So like Ryan kind of mentioned in his talk, when we're describing our ultrasound and we're writing our reports, we need to know whether it's a complete tear, a full tear, retracted tear, that sort of stuff. So being able to describe where your pathology is it through and through? Is it on the rotator cuff specifically? We're going to do upper extremity, start high, go low. Is it on the articular side, the bursal side? Is it in the middle of the tendon? And also you can have a focal full thickness tear, often on MR, that is described as a pinhole tear. So just being able to describe where that is. Ultrasound can be extremely sensitive and specific and compared to MR, but it is user dependent. So the more, again, the more normal you see, the more the pathology will kind of come out for you. So biceps tendon pathology, I think history is really important for this. Our older patients, when we start to see the rotator cuff tendinosis and the rotator cuff arthropathies, those are going to be kind of more just a kind of a chronic bicipital tenodesis. However, a lot of patients come in with acute pop and might have a Popeyes deformity. So partial tears do tend to be intersubstance. So when you look at that fibrillar pattern on the short axis view or long axis view, you may see some hypoechoic changes in there. Dynamic stress testing can show the defect more clearly. So I'm huge about doing dynamic movement when we do this, and ultrasound should be dynamic. And that's the difference between MR and ultrasound, right? Sometimes we can show things that we may not have seen on an MR. So if you have a complete rupture, it's usually transverse, and you can often tell your surgical partners or in your report say, it's retracted 8 centimeters and try to measure it out. Typically the biceps tendon should sit in that bicipital groove, but dynamically, like Ryan mentioned, his fibular tendons, sublux and all, you can have subluxation of the bicipital tendon out of the bicipital groove also. So this was a patient who came to me who is a triathlete and had all this pain and swelling, and she was doing a half Ironman and said, "Can you give me injection? It hurts now when I run or when I ride my bike." When I looked at her huge biceps tendon sheath effusion, so that automatically is telling me, hey, when you see a target sign like that, that is often related to rotator cuff pathology. When I started getting into it a little bit more with her, she had crashed her bike and fallen on her shoulder a couple of weeks ago and was just trying to train through it. So in most of these pictures, you will see I'll put a little demographic of where my transducer is lying, my kind of the position that I have. So this can be just a true biceps tenodesis, but it is also, it's very much highly associated with rotator cuff pathology. So the subscapularis tendon is a tricky one. It has tendon slips in it. So those tendon slips can be mistaken as a tear for dynamic, sorry, my dog just busted in with dynamic range of motion. So it's good to use dynamic external rotation to help visualize this. The subscap does attach to the lesser tuberosity, and I always make sure you have to scan that full subscap tendon from inferior to superficial. The rotator cuff interval is a very important anatomic structure for injections, but also most common place to have a rotator cuff tear. So in this bottom picture, you can see our subscapularis is more anterior. We have the biceps tendon right where it's starting to go, right before it goes intra-articular, and our supraspinatus tendon posteriorly. So just be aware that when you're describing something or when you're scanning something, knowing where it's at. Is it the more anterior portion of the subscap? Is it at the rotator cuff interval? Where are we seeing that? The long axis view, if you look at this, we do have a kind of a bursal sided frame and some intra-substance hypoechoic signal here. And then the subscap, when we look at it short axis, this is more than just that tendon slip I was seeing showing on that previous picture. It's more hypoechoic tendon. There's cortical regularity noted on the lesser tuberosity. That cortical regularity is a secondary sign of a rotator cuff pathology. Supraspinatus tendons, like Ryan said, with the Achilles tendon should be pretty obvious if they've torn this. We place the patients in a modified cross position where we're pulling that humeral head from below the acromion and the clavicle. So you really need to think about the dynamic of that shoulder is as we're moving that shoulder and we're moving them internally, externally, anteriorly. Sometimes that modified cross, not only are you pulling that humeral head forward, you sometimes get a little bit of internal rotation. It's a very uncomfortable position for patients to hold if they have pathology. So it's good to look at this, you know, in both the short axis plane. I tend to do my supraspinatus scanning last because it's the most uncomfortable. So I'll scan the shoulder anteriorly, go back posteriorly, and do my supraspinatus last. But on this patient, this is actually one of our athletic trainers who worked in the office. He was doing a burpee challenge with one of my partners and felt a pop in his burpee. Immediately scanned him. So literally I scanned him probably 5 minutes after he felt the pop in his shoulder, and he has a full thickness supraspinatus tear there. So they should be pretty obvious. It's more subtle when you have the partial thickness ones. And this, the infraspinatus, when we go posteriorly, infraspinatus, it's nice, it's horizontal with the spine of your scapula. It should be a pretty easy tendon to see. It's got a nice long tendon imprint. Again, that internal rotation, external rotation will help you identify it. This is a patient who slipped and fell on the ice, and she had negative x-rays at urgent care and then had seen her primary care. 5 weeks later was still having pain. So you can see the nice picture of the infraspinatus humeral head on her glenoid here. So on this picture, I can see she's got just some hypoechoic signal. Again, we see that cortical irregularity, those secondary signs of rotator cuff tears. But then when I started dynamically moving her, one, I can see an effusion here. But as we get her into full external rotation, you can see she's actually got an undersurface tear of her infraspinatus here too. So it's a partial articular sided tear. The teres minor is a little bit more difficult to see. It's got a much shorter tendon stump. So we're going to take that transducer and go down at a 45-degree angle. If you get down to the quadrilateral space and see the axillary nerve pumping, artery pumping, you've gone too far. So come back up from that. So that's, again, where you can use your Doppler if you see something pulsing. It's helpful to have the patient in full internal rotation. And again, in long axis, we're in that 45-degree angle. In this video here, this is an 83-year-old female who was sent to me from one of my spine partners to rule out rotator cuff pathology. They kept saying it's her shoulder, it's her shoulder, it's her shoulder. On this video, as we scanned through, the teres is actually back here posterior. This is our infraspinatus. But she had a lot of fat atrophy secondary to chronic cervical radiculopathy. So disuse fat atrophy we'll see as this kind of hyperechoic structures within a hypoechoic muscle belly. So be aware that you could see fat atrophy on ultrasounds also. The glenohumeral joint is pretty easy to see. You need to move that probe a little bit more medial and inferior from your infraspinatus eval. The posterior glenoid and the superior labrum and even the inferior labrum can be seen. However, what I found is, like with patients with large body habitus, if I'm really wanting to look at the bony architecture, if I use my curvilinear probe, I can get a better signal from the curvilinear probe on the bone refraction. But if I want that really clear cut picture of the cuff or looking for a labral cuff, I might need my linear transducer. So often I switch back and forth. So I might start with my linear, switch to the curvilinear, and then go back. So on this, you might see a paralabral cyst picture compressing the sphenoglenoid notch. You might see some cortical irregularity. You can actually see very commonplace to see Hill-Sachs deformities, or even sometimes you can even catch a bony bank heart if you can get that in plane. But again, ultrasound, not great for intra-articular pathology. So if you're truly looking for a slap tear, unless this fibrocartilage labrum, which is right here, is completely pulled off, you may need your MR with arthrogram to see that intra-articular pathology. Glenohumeral effusions. This is the triathlete patient that I told you all about earlier who crashed her bike. So once I looked at that biceps and I go, oh, that's not pretty. We got to go back and look at the rest of her cuff. So she actually had a huge glenohumeral effusion. And if you can catch here on her humerus, she's got a little step off there. So she actually had a non-displaced proximal humerus fracture, and then had a huge glenohumeral effusion, big old subdeltoid bursitis, and then actually had completely torn her supraspinatus. So the crazy triathlete that she is, she did her race and waited until after her race was done before she decided to have anything surgical done. So that little step off on the humerus, if you catch those could be also a trauma associated, that may be a small fracture. So as we're going down to the elbow, again, this is a lot. We teach for a full day in the fundamentals and the advanced course on some of these structures. So just we're really trying to hit the high points here. I can almost guarantee you're going to get a lateral elbow question though. So the common extensor muscles and the common extensor tendon are really fairly easy to identify lateral. We also talk about the radial capitellar joint. You might see an effusion there or a step off with a radial head. I actually had a question on one of my vignettes that was a step off on a radial head with a radial capitellar effusion. And it was an ultrasound picture, but the answer was a non-displaced radial neck fracture. So just be aware of those. We also have the radial collateral ligament in our buccal, annular ligament complex, posterior interosseous nerve. They might have a question about a normal lateral common extensor tendon picture, and the patient has been refractory to treatment, what other pathology could be, and that could be your PIN. And then also looking at your brachioradialis and ECRL proximal attachments there. So just really knowing your anatomy is key to most of our musculoskeletal ultrasound vignettes. So when we look at this, here's our lateral radial capitellar joint, radial head, nice little appearance there. The common extensor tendon is always going to be the top of the lateral epicondyle. Some people have a more, this patient has a nice ski slope appearance of that lateral epicondyle. Some people's are more blunted. Everyone's anatomy is different. But the radial collateral ligament is that bottom 40% of the lateral epicondyle. And then it blends in with the annular ligament over the radial head. The annular ligament is best seen in, I think, in short axis view over that radial head. So just be aware that never inject into the radial collateral ligament or never tenotomize into the radial collateral ligament. So be very aware of how that anatomy sits. Here's some pathology. So again, you might get a vignette with a picture of an intersubstance tear and you need to be able to identify it. This is a post-op patient that was sent to me for a diagnostic tear or diagnostic scan after they had had an open surgical procedure. So you can see this artifact that is actually suture where they'd gone and sewn or repaired them. And here is a nice picture of a full thickness proximal radial collateral ligament rupture. Medial elbow, Ryan had some great pictures in his portion of the talk too. So the common flexor tendon is a much shorter tendon than the common extensor tendon. And it's very superficial. So just know that your pronator mass is deep to that. And, you should never be injecting down into the pronator mass. That common flexor tendon, pretty easy to follow all the way out to the myotendinous junction, but it's a pretty short tendon imprint there. And then when we're on that common flexor tendon, we're pretty much just very vertical with the medial epicondyle. When we go down to the ulnar collateral ligament, you're going to kind of rotate or toggle down. I always say pivot from the medial epicondyle down about 45 degrees. And then you should be able to get a nice picture of the ulnar collateral ligament from the medial epicondyle to its attachment down onto the ulna, the sublime tubercle. The ulnar nerve is a nice big fat nerve. So it should have this honeycomb structure Ryan mentioned in his talk. But what I always warn my patients too, if I'm going to do treatment on the common flexor tendon, whether it's a tenotomy or we're doing PRP, if you're doing any sort of anesthetic, because that ulnar nerve sits so superficially, they may get a little anesthetic into that cubital tunnel too. So be aware of that. And you can also look for dynamic subluxation. So here's just a couple older pathology pictures. So here we can see this medial epicondylosis with the, there's actually cortical regularity over that common flexor tendon attachment. And then again, the injection, if we're doing an injection, you need to be very superficial. We would never want to see that needle coming in down at a 45-degree angle into the pronator mass. I had a vignette on de Quervain's tenosynovitis on mine. So, and one of my fellows was so kind to review some of these questions with me. And she had a question on de Quervain's on her board CAQ prep book. the APL and the EPB, super easy to see in that first dorsal compartment. Typically the APL will sit a little bit more radial and deep, but like Ryan mentioned, everyone's anatomy is different. So this was a new mom that came in with a big fat swollen, and you could see the swelling visibly at that radial styloid. So long axis view here, you can see the radius, the tendon sitting here, and the just swelling superficial. But when I looked at it on short axis, and you can see in this video, a lot of tendon slips in that APL and EPB, even to the point where it's difficult for me to determine which one was which. What I have learned from my hand surgery colleagues is that anatomic variant almost always needs surgical intervention because of those multiple tendon slips. They just don't do as well when you see those nice two little balls right next to each other in short axis view. And here's an injection. Very superficial injection. So this is with the value averaging of the ultrasounds. Really make sure you're looking at both short and long axis views, so you're not doing an intra, putting the injection all the way into the middle of those tendons. Carpal tunnel syndrome, one of the most common things I think we use in hand and wrist to diagnose. This can be post-traumatic. I do a lot of post-traumatic ORF scanning of the median nerves for some of my hand surgical partners. They just found that's a quick, easy way for me to look at it instead of having to get an EMG, especially if it's an acute carpal tunnel syndrome that they're concerned about. Ryan showed a lovely picture of how you can see that nerve get really swollen. Again, you'll see hypoechoic enlargement, but a lot of great studies that if you do if you measure this, if there's more than 10 millimeters of the cross-sectional area is really highly sensitive and specific for carpal tunnel syndrome. You can give lectures on this. There's a million studies over there. So just know that your proximal carpal tunnel structures and your distal carpal tunnel structures, and being able to measure those cross-sectional areas. Newer studies have showed even over 9 millimeters of that cross-sectional area is pretty diagnostic for carpal tunnel syndrome, with a sensitivity of 87.3%, specificity of 83%. So, and there are insurance companies who are allowing this instead of an EMG nerve conduction study test for their diagnostic criteria for intervention. Injections, typically we do these injections volar wrist, at the crease of the wrist. You can do an in-plane or out-of-plane approach, but in-plane approaches have been found to be a little bit more accurate when they went and looked at post-injection scanning to make sure the injectate went where it got. But it's sometimes patients' anatomies are different, so you may have to change how you approach this. Always use your Doppler to avoid the ulnar or radial artery. I've had patients who've had some trauma or had some arthritis, and I can't do that ulnar to radial approach, so I might have to do a radial to ulnar approach. But as long as I'm aware of all the structures of the carpal tunnel and know where my artery and vein are, that's great. You can see the retinaculum here over the top, and I really try to do a hydrodissection off the retinaculum because the studies have shown that there are better outcomes with that. Trigger finger, super common to scan. Doug Hoffman can give a whole lectures on hand pathology, and he has amazing images and amazing lectures. This is a patient that came to me, and we're looking at the IP joint here at the A1 pulley, and I could see some thickening, and I could tell that the tendon wasn't flexing and moving well. And there's this kind of weird structure here, but it was difficult for me to keep it on plane with some of the dynamic imaging. But this was actually a ganglion cyst that was coming off their A1 pulley. And this was something that my hand partner was in with me, and he said, "Hey, can you just stick a needle in it and see if you can pop it?" I said, "Absolutely." So this is a short axis view. So you can see my needle right here in the ganglion cyst. And we basically just tried to perforate it because it was so small. It only measured 5 millimeters in circle. It was only 1 millimeter across. So we just basically kind of perforated it with the needle, and the patient did great with care to try to avoid your flexor tendons there. Gamekeeper sum, really great dynamic tests that you can do. You're going to see a lot of this. We have a big flag football community I've started to see injuries with younger kids, and skiers thumb. If you live in the mountains and you have a lot of skiers, you might see of this. I've never had anyone who's been a true gamekeeper and got it from breaking a bird's neck, but still young in my career, I suppose. So this is a nice picture from the ultrasound case infos, where you can see the ulnar collateral ligament torn back and kind of fallen down. We're always looking for a Steiner lesion. With this, when you do a dynamic test of the ulnar collateral ligament, you're looking for dynamic opening and widening. This is actually my medical assistant. She fell and caught her finger, and we can compare it to the other side, and we could see that she was dynamically opening, but I can see ulnar collateral ligament. You can see a fibrillar pattern going all the way distal, but you can get this idea. There's this hypocoque area where she probably has a high-grade partial tear. We did follow this up with an MRI, and it did confirmed that she had a non-Sener type UCL tear and a little 5 mm gap there. She also had a little microtrabecular fracture from the fall. So the good news on hers is she was able to treat it non-operatively, but it's a nice dynamic scan that you can do. You might also see a ultrasound vignette with first CMC joint arthritis that you can see some effusion and swelling on too. Masses, bumps, and lumps, again, not always the most exciting thing to scan with ultrasound, but I was surprised how many tumor questions I had, and maybe it was only 1 or 2, but I think it just surprised me because you don't always think about masses, bumps, and lumps as being musculoskeletal ultrasound. Baker cyst is probably the most common thing you're going to see. You can have a complicated cyst. You may have a simple cyst. On the left here, this is a complicated cyst, multiple septations, a little bit of hyperechoic signal in there, some floaters in there. You might see some refraction in there. On the right side of the screen, here's an aspiration with a more simple cyst. And even what Ryan mentioned, it could be a still picture with that needle in there. And then it may say what tendons sit superficial to that Baker cyst. And you need to know they sit between the semitendinosus, semimembranosus, and then the gastrocnemius. So again, it's identifying what's on the picture, but also knowing, clinical application to that. Ganglion cysts, super common. Most common place is going to be off the dorsum of the wrist, but very common to get them volarly on a wrist. This is off the radial carpal joint. So this is the scaphoid distal radius, small little ganglion cysts. And this was a tennis athlete who decided to go ahead and have an aspiration and an injection in season. So you're just looking for that. They're typically firm. When you put that sonopalpation that Ryan was talking about, that may cause some pain, but these should also not be compressible. So you should not see the fluid shifting and moving like you might with like the biceps tendon sheath effusion or, some other structures. This was actually an 18-year-old gymnast who came to me just a couple of weeks ago, and she just had a lump on her toe. It was atraumatic. She's been in the gym. She tumbles. She does all of her gymnastics. She's going to go to a Division I school and do gymnastics in college, and just had this weird swollen lump on her toe. It was when I looked at it, I said, well, let's just plop the ultrasound on and see if I can see what it is. I was 100% expecting this to be a ganglion cyst, and it was not. It was this kind of solid appearing mass. There was no refraction to it. This is her proximal phalanx. You can't see her first metatarsal head there much, but I actually aspirated it, and it got this thick white fluid. It was not like a typical appearing fluid, and it actually came back with lipid particles, which could be consistent with an intra-articular fracture. So we ended up getting an MRI, no IA fracture, but she was referred to rheumatology because she has had a lot of other kind of multiple joint complaints. And then one of my foot and ankle surgeons actually removed it this week and sent it for pathology, but we don't have the pathology back. So, and he said to me, I said, what did you think it was? And he said, I have no idea. We'll see what it shows. So it was kind of interesting. This is a 42-year-old male who has a post-traumatic wrist OA that came in with a volar wrist mass. So just came in all big, swollen, had a really bad Colles fracture when he was much younger that was treated non-operatively and kind of healed in not a great way. So again, put the ultrasound on. This is a volar mass. You can say this is a complicated mass, maybe some crystals in there. I was thinking, oh my gosh, is this gout? Is this something else going on? When I aspirated on the right here, you can see there's all these thick floaters and synovium in there. So we did a synovial fluid aspiration, and it was actually no crystals. And so this was a synovitis. We aspirated him. You can see I aspirated about 2.5 milliliters off of it. We got pretty good, decent collapse of that. Interesting, the Doppler was completely normal on this, but we did do a little corticosteroid injection, and I referred him to hand surgery if it recurs, if he doesn't want to keep doing aspirations. Morel-Lavallée lesions, I have no clue if I'm pronouncing that right. So anyone who has a French background, I apologize, but that's how I've always said it. This is one of my Xavier soccer kids who was running, and it was kind of, the ball was on the line. Unfortunately, at Xavier, our bench is super close to the sideline, and he got kind of taken out, slid along the bench, his thigh slid, and had swelling on his anterolateral thigh. He had kept going. It was one of those things we all kind of went, oh, that looked like it hurt, but he kept completed the game. And then after the game, you can see he's got this hypoechoic fluid behind the below the subcutaneous tissue, but above the muscle. So those lesions, there's a tissue shear, and then it fills up with fluid. So luckily we were able to aspirate him before he got a big hematoma or anything. Kept him in a thigh compression sleeve, and he did great. It resolved on its own. I've also found anecdotally, I have no research that backs this up, but doxycycline sclerosis can actually help those quite a bit if they keep filling up with fluid. Lipomas, I want to thank Brennan for this picture. These are going to be a well circumscribed ovoid mass in the subcutaneous tissue, but they can be intramuscular. The thing about lipomas is you can see they can have septations in them, variable echogenicity. So you may have, it may be hyperechoic, it may be hypoechoic, or it could be a mixed picture in there. So just realize that they're not very uniform, but usually you can see the capsule around them. They usually have a pretty well-defined capsule. So in this picture that Brennan provided, you can see they've got a nice thick outer capsule, and then you can see the muscle deep to that. No acoustic shadowing, and they should not have Doppler flow in them, maybe minimally, but there should really not be any Doppler flow in there. So if it's large and there is some Doppler flow, you need to be concerned about a liposarcoma, and then that patient needs to see one of the tumor oncology orthopedic physicians, or have an MR with and without contrast. And here's Jake lent me this picture too. This is a nice picture of an intramuscular lipoma, just superior to the supraspinatus in the deltoid. So here you can see the deltoid muscles coming at us, supraspinatus. It's a little oblique off plane, but you can see this nice ovoid intramuscular lipoma. And then a parameniscal cyst. This is a patient, actually saw her back again today. She's a 38-year-old female with a history of ACL reconstruction. She has a little bit of mucoid degeneration of her ACL, so has a little bit of extra laxity in there. She is a competitive rower and competes on a national level and internationally, and just has this kind of swelling that'll come and go on the side of her knee. She noticed after a competition last week that she had some increased pain and IT band tightness. Her knee occasionally just feels tight. She'll swell. So we've been doing visco supplementation to help her with that, but pop the ultrasound on, and she's got a nice little parameniscal cyst. So this is her tibia, medial femoral condyle, or femoral condyle here. I'm sorry, lateral femoral condyle with the popliteus. And then this is her hyperechoic meniscus right there with a nice ovoid parameniscal cyst. And again, with sonopalpation, that is firm. It does not compress, non-compressible. And that is then for me.
Thank you both, Dr. Dixon and Dr. Kruse, for such a great overview, but also in depth. I think it was really wonderful how you were able to sort of embed your examples and possible questions in there. I think I'm taking the boards myself this fall. I'm going to plan to watch this about 5 times. The pictures are great too. We only had one official question come in, so I thought I would just check on that. We'll touch base. Let me see if I can get it. The question was, what's the difference between Doppler and power Doppler? And specifically, how does that have an effect on better looking, better considering neovascularity?
So power Doppler, and Ryan, correct me if I'm wrong, but power Doppler actually measures the strength of the flow. It doesn't tell you anything about whether the flow is flowing towards you or away from you. So it's often used for like peripheral vascular disease. I don't ever use I have the power Doppler settings on my ultrasound, but I really don't use them. So it might be useful if you have a really, really small peripheral vessel and you're trying to see if that's a pumper or not. And sometimes when you put on the power Doppler, it will give you a wave flow analysis too. But it doesn't give us the red or blue. It just is one picture, and it's more measuring the strength of the blood flow through that area. So I don't use it for neovascularity or anything like that.
So I would say standard color Doppler. I mean, the reason to use that would be to look for directional flow. And that's really the primary reason to use it. Power Doppler is not going to give you any directionality. However, it is more sensitive for slower flow vessels. So I think if you're looking at tendons, for neo vessels, which are very slow flow vessels, I think Power Doppler is your better option there. There are other proprietary types of Doppler that certain machines have, but I guess to generally answer the question, color Doppler looks at directionality, Power Doppler, no directionality, but Power Doppler is more sensitive for low flow vessels.
So I use the power Doppler setting a lot. Again, if I'm in like this small area and I'm like, is that a neo vessel? Is that it'll kind of pop it on? But I typically almost always just hit my color setting because most of the newer machines I think are pretty sensitive for that. So
Great question and great answer, of course. We have gone over time, so I think we might officially end the recording. But then if people want to stay on or ask any questions or pop onto the video and ask our experts a question or thank them for their time, you're welcome to.